Hello and welcome everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own tumor defeater, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers to access the right treatment at the right time. Today, we will be diving into the evolving landscape of prostate cancer, which is the most common cancer in men. From precision diagnostics and genomic profiling to next generation therapies like PSMA targeted therapies and immunotherapy, the line against the treatment, the fight against prostate cancer is entering into a new era. So, therefore, join us to explore the breakthroughs in prostate cancer today. Without much further ado, let me begin by introducing our doctor to you. Dr. Krishnamani has been associated with AY hospitals here in Hyderabad since the past decade. He is well versed in managing solid tumors and hematological malignancies. He has continually expanded his knowledge and skills by completing fellowships in prestigious international institutions. Throughout his career, he has been an integral part of various hospitals and organizations across India, earning the recognition as one of the country's leading oncologists. He has served on the advisory board for clinical research. His commitment to advancing the field of oncology is further demonstrated by his membership in American and European oncology societies. Welcome to you, sir.
Uh, Hello, everyone. Welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness on cancer. And today, let's discuss, as you said, something on prostate cancer. And then let's go a bit deeper, if time permits, into the disease.
So, sir, can you tell us what are the current trends in prostate cancer incidence and survival rates now?
So, as you said, prostate cancer is an extremely common cancer. Uh, it is one of the most common cancers seen in men. And the incidence is rising. Survivals are also rising. Why is the incidence rising? Because prostate cancer is detected with a blood test, which is called a PSA. So now, for example, in India, rampantly we are doing PSAs for everybody as part of cancer screening program. So you go, an adult goes, he wants to get a PSA done, he can get it done. So that what happens in that is your normal value is less than 4. Now, PSA is a test which is not prostate cancer specific. It is prostate specific. So understand the difference. So if you have a prostate infection, prostatitis, PSA will go up. If you have benign hypertrophy of prostate becomes large in size in old men, PSA goes up. You have prostate cancer, PSA goes up. So PSA can go up in either of the three conditions. So it is prostate specific, not cancer specific, but one of the common causes is cancer. Very high PSAs means you probably have prostate cancer. Now what's happening to the incidence is rising because everybody can get a prostate specific antigen blood test. So now if you have a PSA of 8, does it mean you have cancer? No, you could have a urine infection, prostatic infection, BPH. But what happen? You will undergo a biopsy. Suppose you have a small focus of cancer. So you have very, very early prostate cancer maybe. It is asymptomatic. You had no problems. You just went and got a test done. But because of which now you have been diagnosed as cancer. So that is why the cases are going up. So what we should also understand is prostate cancer can present like this. That is completely asymptomatic people going for routine master health checkups, raised PSA in their blood, they get evaluated, they have prostate cancer. So they are perfectly fine. Just a blood test says you have cancer. Some people have lower urinary symptoms, like they're unable to hold urine. Before they go to the washroom, there is dribbling. They go multiple times. There is urgency. So these are also seen in BPH, the benign part, the normal non-cancerous part. So these are some of the symptoms. Sometimes the cancer can spread to the bone, where it can cause severe bone pains, and then because it has spread everywhere, it can cause weakness, weight loss, anemia, fatigue. So that is another common presentation. So these are the three general ways in which we are able to detect new cancer patients who have CA prostate.
So, can you just tell us in brief what would be the typical symptoms of a person who's suffering from prostate cancer?
Symptoms are, as I told you, one, you could be asymptomatic, one with only a PSA rise, one you could have a lower urinary symptoms like urgency, frequency, going to the washroom multiple times at night, bleeding in the urine, etc., or pelvic pain. Third, you can have spread to the bones and cause bone pain, fatigue, anemia, weakness, loss of appetite, etc.
So how has the role of PSA testing changed with emergence of newer diagnostic tools, especially in the landscape of prostate cancer?
I'm sorry, what was the question? How was the
Role of PSA testing changed with the emergence of newer diagnostic tools in the landscape of prostate cancer?
No, PSA will be your go-to test. It's a simple blood test, right? Like a CBC. So that is your go-to test. That will be done. It will be the initial part of your workup. It's a very simple test. Put a needle, take a sample, send it, get the report in 1-2 hours.
Any role where genetic testing would play in prostate cancer?
All prostate cancer patients ideally today should have genetic testing, or we call it HRD testing, human recombinant deficiency. Also, we do something called MSI, which we discussed in our previous episodes. So send the tumor for HRD, BRCA1 and BRCA2, send the blood also for BRCA1 and BRCA2. This is mandatory.
So, can you tell us a little bit more about MRI guided biopsies and how they would compare with the traditional biopsy method for prostate cancer?
See, what we should understand is it's a pelvic organ. So MRI is better suited to give you a picture. Rather than a CT, MR is more better in giving you a clearer image. MR also tells you in the prostate, there could be BPH, but some suspicious areas of cancer are there in a particular zone, which guides the radiologist to do a biopsy. MRI also gives you the extent of spread within the prostate, extent of spread outside the prostate to lymph nodes, extent of spread beyond the lymph nodes to the bones and other organs. So the MRI is useful for giving a suspicion of a lesion. So there is a score called PIRADS score, like BIRADS, breast imaging score in breast cancer. This is prostate imaging score. If the PIRADS score is high on MRI, it means it is a suspicious cancer, get a biopsy. It can also tell you, the MRI, whether the disease is spread to the lymph nodes or not and other organs. And obviously the MR gives you a very clear navigation to get a tissue.
So, now when we talk about advances in the diagnostic profile for prostate cancer patients, are there any newer advancements which are being done?
PSMA PET CT scan. So we do a FDG PET in general patients, right? General cancers, normal cancers, we do FDG PET. PET is a PET scan, positron emission tomography. So what is a PET? PET and CT are together. CT gives you the image, morphological image. PET gives you the activity, whether it is active or not, whether it is, to put in simple words, alive or dead. So metabolic part is given by the PET scan, which is measured by something called SUV, standard uptake value. Anything beyond 2.5, 3.5 is considered abnormal. Normal below 2.5 doesn't mean it is normal, but I'm just telling you. So PET CT means on the CT you find whatever disease you have. PET will also light up. For the PET we use fluorodeoxyglucose, that is one of the tracers. It's a contrast. That is in normal cancers. In prostate cancer, we do a PSMA PET. So that is a different tracer. So that is a newer modality. So for prostate cancer, we don't recommend regular PET CTs. We recommend PSMA PET CT. It gives us more clarity. It is more sensitive. It is more sensitive in picking up disease which other scans have not picked up in certain areas. So the extent of disease can change on a PSMA PET CT scan. So that is a newer one. The other newer modalities which we use is your next generation sequencing. We test for MSI, TMB, tumor mutation burden, HRD testing, and we also test for BRCA1 and BRCA2. You have to do this in a prostate cancer patient.
So, can you tell us some of the latest advances in hormone therapy for prostate cancer?
So keep things very simple. Prostate cancer is a male disease. Prostate cancer is a hormone driven disease. What hormone? Testosterone. You reduce the testosterone, the cancer will come down. How do you remove the testosterone or reduce the testosterone? Two ways. Either remove the testis surgically, which is a permanent procedure, or from the testis, the testosterone which comes, you block it before it attaches to the receptor. That is with the injection, which is given every 3 months or 6 months. But this is a temporary thing. Every 3 to 6 months, you have to keep giving the injection. So surgically remove the testis or block the testosterone. Once testosterone is not there, PSA will fall. Once PSA falls, the cancer starts falling down. On this, now we have a lot of advancements. We have other hormonal medicines like bicalutamide, flutamide, apalutamide. So the cancer, the testosterone axis, we call it. There are multiple levels. At each level, there are medicines blocking it. So all these medicines added up to orchidectomy or to medical management of castration, we say. This increases the survival of the patient. This reduces the disease.
Does immunotherapy play any role for prostate cancer patients?
Yes, in those who are MSI high, those who are TMB high, immunotherapy has a role. So these patients are exquisitely sensitive to immunotherapy. I'll give you a small example. We have a patient. He had prostate cancer way back in 2015 or 14. He did well till 2020. His PSA came down. It was 40 or 50. It came down to 0.1, 0.01. He was treated elsewhere after that. Then what happened is he started developing symptoms. His scan became very bad, spread everywhere, lungs, bone, liver, etc. But his PSA was always 0.001, 0.002, which is very, very, very low. He was given all kinds of chemotherapies for prostate cancer. He came to us. We found there is a missing link. Your PSA is so low, but your disease is so bad. So we did a rebiopsy. Why you should do a rebiopsy is prostate adenocarcinoma can transform in the future. In adenocarcinoma, PSAs are high. In transformation, PSA will be low. So your adenocarcinoma treatments will not work for this. So we did a biopsy. It came as transformation. On that, we did your genetic markers, MSI, TMB. Both were high. 80-plus-year-old person. He was put on immunotherapy. He's doing extremely well even today after 3 years. He came on a stretcher, bedridden, about to probably, we would have lost him in 2 or 3 months. Today he walks in a wheel. He comes in a wheelchair. He walks on his own with a walking stick at home. Disease is in remission on immunotherapy. How? Because he was MSI TMB high. It works. How did you do MSI? You did a rebiopsy and you checked it. So immunotherapy has a role in high MSI TMB. It will have long results and durable results.
So, this was about the MSI and the tumor mutation burden among the prostate cancer patients. Sir, can we also talk about the BRCA mutation which are present in the prostate cancer patients?
Yes, BRCA is common in prostate cancer. BRCA can cause breast, ovary, pancreatic, and prostate cancers. The chances of getting prostate for BRCA patients are between 5 to 15%. If you have BRCA positive or HRD positive, you will be put on medications called PARP inhibitors, which are tablets. So what it does is it kills the cancerous cell, thereby it improves your prognosis.
So, when we talk about advances in prostate cancer, now there is a scope for giving personalized treatment also to patients. So, would that be followed for all the patients who are having prostate cancer?
So this is only a personalized treatment. BRCA positive, treat with BRCA; HRD positive, treat with PARP inhibitors; your MSI TMB, treat with immunotherapy; other patients treat with abiraterone or enzalutamide. There are a lot of radiation for select patients who have very local disease. Then you give your lutetium therapy for patients who have failed on chemotherapy. So you are trying to give one kind of treatment for one kind of person.
So, sir, would you also say that prostate cancer has also evolved into a cancer which is requiring multidisciplinary teams to work together to provide best treatment for the patient?
100%. If your disease is in the initial stages, localized, you will probably need a surgeon, you will need a radiation oncologist and a medical oncologist. Early cases, localized cases, you can either remove the prostate or radiate the prostate. Once you become advanced, again, as I said, you will remove the testis surgically or you can medical management. And once you have severe bone pains, you will need a radiation oncologist to control the bone pains and a radionuclide therapist for giving lutetium therapy. So it is a multidisciplinary effort.
Sir, what questions should men be asking their doctors about prostate health and about prostate screening? At what age should they be asking, and what exactly should they be asking their doctors for it?
So average screening you can start probably at the age of 50 years or so. Average screening, talk to your doctor. Average screening maybe you can start at the age of 50. If you have a genetic risk, if somebody in your family is BRCA positive, if you have a family history or somebody in the family with prostate cancer, begin screening early, maybe at the age of 40 or 45. How do you do? Do a PSA test.
Okay, sir. So now we will go on to bursting a few myths about cancer. So, the first one is a very common one. Only elderly men get prostate cancer.
No, it is very common in elderly, but people above 40, people above 50 can also get. So many times what happens is people may die with prostate cancer, but they never know they had cancer. Somebody may live up to 90. He may die with old age or stroke or heart problems. He may probably be having very early stage prostate cancer within himself, which was never diagnosed. So it is a disease very common in the elderly, but can be seen in the young.
The second one is that if a person has a high PSA level, it definitely means that they will have prostate cancer.
Uh, High means how high? If it is between 4 to 10 or 15 or whatever, between 4 to 8 or whatever, you could have other causes also like urinary infection, prostate infection, BPH. But beyond 10, you should work them up for prostate cancer.
The third one is that if I am getting immunotherapy for my cancer treatment, I will not have hair fall, hair fall or nausea, vomiting, which is commonly associated with the other drugs.
Correct. Chemotherapy causes a lot of hair fall, nausea, vomiting, and all that. Immunotherapy generally doesn't cause hair fall. Fatigue is a common thing in immunotherapy. Thyroid problems can happen. You can have pneumonitis. You can have pancreas and liver issues and skin rashes and all that.
Thank you for this session, sir. Can you please summarize this session for our audience?
Prostate is an extremely common cancer seen in men. Most of the time, it is presenting in early stage or locally advanced stage. In those stages, surgery or radiation is a very good treatment which will help you in cure. And then you will need regular PSA monitoring every 3 to 6 months. If your PSA rises, your doctor will tell you that the disease is probably coming back. On the prostate cancer specimen, in the biopsy, it will look as an adenocarcinoma, and we do some scoring called a Gleason score. Prostate cancer also commonly spreads to bones, so patient can present with back pains. That time you may have to radiate the bones to reduce the pain. And hormonal therapy is the treatment to reduce the testosterone. Once you do that, your hormone levels come down. On the hormonal treatment, we also add other hormonal drugs like abiraterone, enzalutamide, or chemotherapy drugs in the future if the disease recurs, so the life of the patient prolongs. Generally, even in stage 4, patients do well for a long period of time. And finally, prostate cancer over a period of time can transform into other types where the PSA becomes low. And all prostate cancer patients should undergo genetic testing for BRCA HRD and MSI and TMB, so that to know whether they're eligible for BRCA medicines, which are olaparib, which is your PARP inhibitors, or your immunotherapy.
Thank you for today's session, sir. Can you please enlighten us about the second opinion campaign which is being run by you?
So on Cancer Reach, we have a second opinion campaign. This is to reach out to patients. It's free of cost. Reach out to us with your queries and we'll respond to you within a day or two with what best we can. This is only to give you a guidance so that wherever you are, at least you get an oncology guidance to move forward and meet your nearest oncologist so as to help the patient's life.
Thank you for taking time out for today's session, sir, and we hope to see you again next Friday.
Thanks so much. See you.
Thank you,
Bye.
sir.
Okay, Katie. See you then.